Welcome to today's web chat about female and male infertility. And thank you for joining us during National Infertility Awareness Week. My name is Ed Bottomley with the Michigan Medicine Department of Communication. 1 in 8 couples have trouble getting pregnant or sustaining a pregnancy. Infertility is not an inconvenience. It's a disease of the reproductive system that impairs the body's ability to perform the basic function of reproduction. Our goal today is to provide helpful information for individuals and couples who are trying to conceive and answer your questions about both female and male infertility. We know there's no shortage of advice from well-intentioned friends and family members, not to mention the internet. So we're also ready to do some myth busting today and to help you sort out the myths from the truth. We'll introduce our panelists in a moment, but first a few housekeeping items. You can submit questions at any time, even now, for our panelists to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but please note that your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you can send us a private message via the social media channel that you are watching on. If you can't stay for the whole chat or you want to share the recording with a friend, a video of the chat in its entirety will be available on our Michigan Medicine social pages later today and also posted to the Michigan Medicine YouTube channel soon after. At this time, I would like to ask our panelists to introduce themselves. Dr. Schon, if you could take it away first.
Thank you. So I am Samantha Schon. I am a reproductive endocrinology and infertility specialist here at the U. So I treat couples struggling with infertility, as well as women who have a range of reproductive disorders like polycystic ovary syndrome, endometriosis, irregular periods, fibroids.
Thank you so much. And if we could pass over to you, Dr. Dupree.
Great. Thanks, Ed, and thanks to you and thanks to everyone for tuning in to this session. And it is National Infertility Awareness Week, so we appreciate everyone's interest in this topic. I'm Jim Dupree. I'm a urologist. I, like Dr. Schon, specialize in infertility, but I specialize on the male side of infertility. So my clinical practice is here at the University of Michigan, taking care of men and their partners to help them in their journeys towards building their families. Thanks a lot.
Thank you so much. And I'll pass over to you, Brandi.
Hi, I am Brandi Walerski, and my role here at CRM is a business system analyst, but I assist all the patients with any financial questions or concerns with any type of fees or prior authorizations, anything like that.
Fantastic. Thank you, Brandi. And thank you all three for being here. Let's kick things off today with a question for you, Dr. Schon. Can you share with us some of the basic challenges couples face during their fertility journey?
Absolutely. So I think just to start, as you mentioned, infertility is a disease that we typically define as an inability to conceive after 1 year of unprotected intercourse. In women over 35, we recommend evaluation after 6 months. As you mentioned, infertility is extremely common, affecting 1 in 8 couples. And as of 2019, over 12% of women reported utilizing infertility services. In terms of some of the challenges faced by our couples, there are both physical challenges related to testing and treatments that can be invasive or uncomfortable. There are emotional challenges for patients and individuals dealing with infertility. Feelings of isolation and stigma are really quite common. And then there can be huge financial burdens for costly treatment that a lot of the time aren't covered by insurance.
Thank you for that overview, Dr. Schon. And we will open up the floor for questions now. I'd like to remind our audience that you can, again, submit questions by commenting on this video, but please note that your name or your profile name will be visible to others participating. If you prefer the anonymous option, you can always send us a private message via the social media channel that you are watching on. So let's kick things off with a question for you, Dr. Dupree. How common is female infertility and how common is male infertility? When a couple is having trouble getting pregnant, how often is it because of the female, the male, or perhaps both?
Yeah, well, thanks, Ed. And I think one of the really unique things about infertility is that it's really the only medical diagnosis that I can think of that actually is technically kind of given to two people, right? So no individual person may necessarily have infertility. It's really when people are trying to build their family that this diagnosis really applies. And so, as both you and Dr. Schon mentioned, we think about 1 in 8 couples in the United States have infertility. And you'll notice that I mentioned the word couples. When we look at couples that are presenting for evaluations, we find that about 30 to 40% of the time after both partners have been evaluated, it's discovered that the primary medical issue is on the female side. About probably 30 or so % of the time, again, after both partners have been evaluated, we find that the primary issue is on the male side. And then in the remaining sort of 20-ish% of the time, 20 to 30% of the time, we find that both the male and the female partner are sort of bringing something to the table that makes it difficult for them to conceive or to carry a pregnancy. If you wanted to simplify it even further, you could try and say about 1/3 of the time it's on the female side, about 1/3 of the time on the male side, and about 1/3 of the time, kind of some combination of both. Although we try very hard not to, again, it's no one's choice to have infertility, right? So there's no one sort of to blame in the situation, but medically, that's what we find when we investigate kind of both members of the couple.
Thank you. I think that's an important point you emphasized at the end there. And as a follow-up question, what tests are the most important to determine fertility?
Yeah, so I'll speak on the male side of that, and I'll let Dr. Schon answer on the female side. On the male side, one thing I can just reassure people that might be nervous to see their doctor is that, a male infertility evaluation is frankly relatively low risk for you and not, hopefully shouldn't be too uncomfortable. The most important things in my mind are really 3 things. One is the history, just talking about what has been going on for the couple and in the man's medical history as well. The second big thing is a physical exam, which is a very gentle examination, kind of mostly focused on the organs that help with fertility, and that's the penis and the testicles for men. Those are sensitive exams, and we understand that and approach them very sensitively. And then the most common test that's performed for men is probably a semen analysis. We will ask men to provide a semen sample. Typically, that's done by masturbating, but there are other ways to collect a semen sample as well. Those are the most common 3 things. We will sometimes also do blood tests, which just involves a standard blood draw from a vein in the arm. Those are the most common things for men. And I'll let Dr. Schon answer for women.
Thank you. So in women, the evaluation sort of aims at assessing the different organs that are important for fertility. So in women, we typically assess the ovaries, and that can be done through blood tests that give us an idea of number of eggs remaining in the ovaries. So there's various blood tests that we do. We often will get an ultrasound to assess the uterus and the ovaries. Typically in couples with infertility, we want to assess the uterus and the fallopian tubes. And there's various radiological tests that we can do to get an idea of whether or not the uterus looks normal or whether or not the fallopian tubes are open and normal appearing. And then generally this visit is also a really nice time to talk about some other preconception testing, checking immunities, discussion of genetic carrier screening, those sorts of things.
Perfect. And I appreciate you, Dr. Dupree, passing that over to Dr. Schon. I imagine there's quite a few of these questions which are really aimed at both of you. The next one we have up, I'll push to you, Dr. Schon, first. How does age impact fertility for men and women?
Yeah, that is a really great question. So of the things that we assess, age is probably the most important factor in assessing overall fertility. As opposed to men, women are born with all of the eggs they're ever going to have, and that number declines as they age. So women actually have the most eggs they're ever going to have when they're a 20-week fetus inside their mother's uterus. And then there's this decline that happens throughout our life. It typically picks up around age 35 to 37. And with that decline in egg number, there's also a decline in egg quality. And so that's why you'll see rates of infertility and rates of miscarriage and chromosomal abnormalities all sort of increase in our later reproductive years. So for example, the tests that I mentioned before that can assess egg quantity really don't tell us about egg quality. Age is really the most important factor when we're counseling people about egg quality.
Thank you so much for that. The next question that we have up, I've heard that older men and women have higher rates of birth defects in their children. Is this true? And I'll push that to you again, Dr. Schon. Please feel free to jump in too, Dr. Dupree.
Yeah, so I'll answer the female side of this and then pass it off to Dr. Dupree. But yes, as I mentioned, again, this biologically has to do with the fact that we're born with all of the eggs we're ever going to have. And if you want to sort of break it down even farther, our eggs are actually frozen in time in meiosis and have extra chromosomes that they need to get rid of before a sperm and an egg, once they fertilize, can then sort of have the correct complement of chromosomes. That process tends to not work as well as we age. And so women over the age of 35 are at risk of chromosomal abnormalities. So these are things where you have an extra copy number. So like Down syndrome or trisomy 18, these are chromosomal abnormalities.
And on the male side, over the past, I would say probably 10 years, there's sort of been a growing understanding that male fertility and sperm quality does start to decline as men get older. I think it used to be thought that a man's fertility was the same throughout his entire lifespan, and it looks like that's just not true. So in particular, when men start entering their 40s, 50s, 60s, and beyond, we do start to see declines in the movement of sperm, sometimes in the quality of the shape of the sperm. And in general, fertility tends to be more difficult for men who are in their 40s, 50s, 60s, 70s compared to when in their 20s and 30s. Now, it's not totally the same as on the female side. There's not sort of a dramatic decline in fertility that happens at any single point in men. It's more of a slow, gradual change. In terms of the offspring, Ed, that was your other kind of part of your question. We do see that children who are born from older fathers do have slightly higher risks of certain birth defects or other sort of genetically other conditions that happen because of changes to genes or DNA. For example, chondroplasia, which is a disorder of the bones and ligaments, is more common among children born from older fathers compared to children born from younger fathers. And I'm sure that probably is, scary or concerning for many people tuning in today. The one bit of reassurance I can offer you is that the rate of those things happening is still relatively low. It is just a little more common when men get older compared to when men are younger. It's still, though, unlikely. Most children born from older fathers are still happy, healthy babies.
Thank you for that, both. The next question for you, Dr. Schon, can you tell us about the Center for Reproductive Medicine here at U of M?
Yes, so the Center for Reproductive Medicine, or CRM, is our main fertility outpatient unit where we see all of our patients. So this is where we see both men and women with reproductive disorders. It's also where we do all of our procedures. So we have a wonderful embryology lab, which is where all of the eggs and sperm and embryos are handled and cultured. And so within this unit, we see patients for their regular visits. We do procedures, as I mentioned, like in vitro fertilization, intrauterine inseminations, office hysteroscopies. Yes.
Thank you. That's a good overview. And
Ed, if I may just
go
mention,
ahead.
The Center for Reproductive Medicine is a multidisciplinary center. So as a urologist, we practice there the same, and For male patients, the same laboratory that Dr. Schon mentioned also does a really nice job with semen analyses and even sperm freezing or cryopreservation for people that may need to freeze their sperm for some reason as well. So it's really a comprehensive multidisciplinary center, which is one of the things that we really like about it. I really like that when I see patients there, Dr. Schon might be down the hall, Brandi's around the corner, we're often all in the same building, which is a really, I think, nice place about the Center for Reproductive Medicine.
Yeah, and sorry, I just thank you, Jim, for bringing that up, because I think that's really one of the unique features, especially about U of M, is that we work so closely with our urologist partners, which is really helpful for our patients, because as Dr. Dupree mentioned at the beginning, this is a disease that affects two people at once. So being able to coordinate their care so closely and talk with Jim is really special and really helpful.
Fantastic. Thank you both for that answer. The next question that I have up is for you, Brandi. Who should I contact to learn more about infertility benefits offered at U of M?
So we encourage to actually reach out to the insurance. There are different policies. So we actually encourage the patients to reach out to them first, especially if it is a specific question. If it's something general, you can reach out to the HR benefits, but we do want to encourage each and every patient, whether it's U of M or any other patient for any other insurance coverage, to reach out to their insurance first. Some good questions to ask them is if they have infertility testing or treatment. That'll give them better insight as to, what they're going to be paying out of pocket.
Thank you for that, Brandi. And as I go through these questions for you, and in fact, the questions for everybody else, if there is a link that we're referring to, if there is a website that we're referring to, we will find that and put it in the comments as well for you guys. The next question also for you, Brandi, if my insurance requires a referral, could this cause denials if I do not have one on file? Who will need to submit the referral? Yes,
this can cause denials. You would need to reach out to your primary care physician. Some individuals know them as PCPs or your general practice physician, family medicine. You'll need to contact them to have the referral sent in. A lot of insurances are becoming more strict, so you definitely want to encourage your primary care physician to reach out and get them established immediately.
Thank you so much for that, Brandi. The next one up for you, are there any discount or payment plan options?
So if you're having any services rendered through University of Michigan, there is a 60% discount on applicable charges. This does not include storage, medication, any type of outside vendors, but when you receive your billing statement, it is not an automatic discount, but you can reach out to Patient Business Services, and their number is at 877-480-8757, and they can review your account, and any applicable charges, they can place that 60% discount.
Thank you. It's so fantastic having you on here to answer these questions. The next one we have up for you, where can I find out how much my plan will cost?
So as you indicated, there is a website for CRM, Center for Reproductive Medicine, and the nurses will be, whenever they send out their plan, when your plan is established, there is a link involved into that message. Once you click it, you will go on to patient resources, and it'll take you to insurance and financial. And once you've already established that with your provider, you can scroll down, it's numerically, and you can look at the plan and select that, and they will provide the estimated cost for those plans. It does also include the genetic testing as well. Again, they are estimated amounts, so you will need to reach out to those carriers.
Thank you again for all of these, Brandi. The next one I have up for you reads, if I have Blue Cross Blue Shield PPO / Blue Cross Blue Care Network, Premier Care, and switch to Physicians Health Plan or Michigan Care PHP, will this reset my $20,000 lifetime maximum benefits?
No, that will not reset. I know a lot of patients are excited that that option was there. However, it is a $20,000 and all insurances work together to tally that balance. And that's another thing too. For the balances, we do encourage patients to reach out to the insurances to see what your remaining balance is for that lifetime.
Thank you. And, you know, on the topic of that lifetime balance, if my partner and I both have U of M policies, does this double the $20,000 lifetime maximum benefits?
It does not, unfortunately.
Thank you. Important answer there.
And Ed, if I can just add one thing that I've noticed as
go
well.
for
Sorry
it.
to interrupt, but patients that see me will often ask, like, whose insurance is it that matters? And you know, for many of the more advanced fertility treatments, like in vitro fertilization or artificial insemination, I always remind my patients that it's really the female partner's insurance that's the one that really applies in that situation. And so if the male partner might work for different companies or have different insurance plans. And so the male partner's plan sort of really describes what happens to him and what's covered for him. And the female partners describes what happens to her and the cost then. Is that fair, Brandi?
It is fair. The patient may be under the partner's insurance. So it could go back and forth. It depends if there's a primary, secondary. It depends if the partner, the patient, is under the spouse's insurance. So yes and no, if that helps.
This all helps. This all helps. And another one for you, Brandi. Are IVF services only covered when they're provided by the U of M Health Center for Reproductive Medicine?
For U of M policies, yes, it does. It covers here at CRM. Now, if you go external, you will be paying out of pocket. It is exclusive to here at CRM.
Thank you for that. Thank you for all of those answers, Brandi. Next question I have up is for you, Dr. Schon. Can you talk a little bit about the COVID vaccine and fertility?
Absolutely. So research shows that the COVID vaccine does not cause infertility. So we're encouraging vaccination among all of our patients, whether they're trying to get pregnant or are pregnant. We do know that pregnant women who are infected with COVID can get sicker and have increased rates of ICU admissions and even death. So we're strongly encouraging all of our patients to consider vaccination.
Thank you for that. And then a question for you on a similar topic, Dr. Dupree. Will getting COVID hurt my sperm count? And what about getting one of the COVID vaccines?
Yeah, I'm really glad folks asked this question, because I know this is a question that's on a lot of people's minds. And I think it's great when patients are able to ask these questions to their doctors. The COVID virus can enter the testicles. There have been studies that have looked at testicular tissue from patients that have recently had COVID, and they've actually seen the virus there under the electron microscope. We have also seen that when men provide semen samples, that when men have had COVID, that their sperm counts will often decline. And our hope is that that's temporary. Of course, we haven't, we've been living with this virus for 2 years now. So I think, unfortunately, there's still more to learn, but and it does look like also that the more severe the infection, the more impact it can have lowering a man's sperm count. Sometimes that may be related to the fever that men sometimes will get with COVID infections, but we also see lower sperm counts in some men that have had COVID that never had an infection. So it looks like it's probably something about the virus itself that can impair fertility for men. Again, hopefully temporary, but temporary might mean a couple of months, or maybe even up to 6 months, depending. The COVID vaccine actually has been studied, and it has been shown to be safe for sperm counts and fertility. There was a nice study that was done at the University of Miami where they took patients and volunteers to give a sperm sample before getting one of the mRNA vaccines, and then after getting the 2 shots, and they found that sperm counts were the same. And so we have not seen any evidence that it will lower sperm count, or that, that the vaccine will lower sperm counts or lower fertility in men. Like Dr. Schon, I strongly encourage my patients to consider getting the vaccine for COVID. I've gotten it myself. I believe it's safe both for overall health, and then in particular, I really believe it's safe for male fertility as well.
Thank you both there. Next question up for you, Dr. Schon. If someone has a history of difficulty getting pregnant and then bears a child naturally, do they have a better chance of getting pregnant again in the future?
A great question. I think that anytime someone has conceived or gotten pregnant, that is definitely a reassuring sign, right? Because they have documented fertility. So I think that that is really encouraging. I think that, you have to consider the diagnosis or if there is a diagnosis, as well as age and the other factors, but it is certainly reassuring when you have achieved a pregnancy before. Now, that's not to say that we don't see a lot of women with what we call secondary infertility, which is, they have achieved or had a pregnancy before and are now encountering difficulties. So, documented fertility is reassuring, but it doesn't mean that there's not a chance of infertility as well.
Thank you for that. The next question we have up, I'm going to send your way too. Are there certain medical conditions or medications that can affect our ability to get pregnant?
Yes, absolutely. So there are a number of medical conditions, medications, and for example, that can be associated with infertility. For example, disorders of the thyroid are a really common condition that can cause women to have irregular periods and difficulty getting pregnant. Women can have abnormalities in their prolactin levels, and that can be due to a medical condition or, some common medications, like antipsychotics. There are other medical conditions that can cause irregular periods. PCOS, like we mentioned before, is one of those conditions. Things like endometriosis, a history of pelvic inflammatory disease. And I'm sure, as Dr. Dupree can speak to, there are also definitely a number of medications that can also impact sperm as well.
Yeah, so thanks. On the male side, I often will think about both medical treatments and surgical treatments, and then as well as medications that can affect them. So probably the most common ones for those tuning in to know and think about on the medication side, testosterone medications, somewhat maybe counterintuitively, can be really bad for a man's sperm count. So taking testosterone, whether it's from a shot or a cream or a gel, or even the sort of sometimes over-the-counter testosterone boosters that get advertised, those actually can lower a man's sperm count. And a long time ago, the World Health Organization actually looked at, investigated using testosterone shots as a contraceptive for men. And they actually found it worked pretty well. And so I really encourage men to avoid testosterone or testosterone-containing products if they want to get pregnant. Other medical conditions that are important to think of, many cancer treatments can impair fertility later on in life, and chemotherapies, radiation, even surgeries, depending on where in the body the surgery was done and where the radiation was applied. Also, medical conditions like diabetes or high blood pressure, smoking can all cause sexual problems in men. So erectile dysfunction or even trouble with ejaculation or orgasm that can make it difficult to get pregnant. And so I counsel men about trying to make sure that their body stays as healthy as possible. And that means eating well and having a healthy body weight and avoiding things like tobacco or marijuana as well.
Thank you both again for answering that question. The next question that we have up, I'm going to push to you, Dr. Schon. It's about polycystic ovary syndrome. It reads, I have polycystic ovary syndrome and I've always been overweight. My gynecologist told me to just lose weight and keep trying to get pregnant. Is this the best method?
Yeah, so it is very common with PCOS for women to struggle with their weight. Among patients with PCOS, it's really easy to gain weight and it's really quite difficult to lose it. And you know, I commend this person for attempting, you know, diet and exercise. We do know that in women with PCOS, if they're able to achieve weight loss, that even a small amount, like 5% or 10%, can help with period regularity. That being said, this can be a really hard thing to do on your own. We actually, a couple of months ago, specifically launched a new clinic out of CRM that's a multidisciplinary clinic. It's called MyCore, the Michigan Interdisciplinary Clinic for Obesity and Reproduction. And it's specifically aimed at our patients with reproductive disorders that are interested in weight management and sort of talking about weight management and the setting of building their families. And it involves, you know, reproductive endocrinologist, an obesity medicine specialist, a nutritionist, a social worker, and a high-risk OB. So I strongly encourage you to come see us for a reproductive endocrinology visit, and we'll be more than happy to help.
Thank you. Thank you for that, Dr. Schon. Next question I have up, I'm going to pass to you, Dr. Dupree. How do STDs affect fertility?
Yeah, so on the male side, sexually transmitted diseases can have a couple different effects. And so one of them is potentially causing a blockage to the flow of sperm. And so certain sexually transmitted diseases can reach the testicles or the epididymis. The epididymis is this kind of a storage gland on the back of the sperm. So after sperm are made in the testicle, on the back of the testicle. After sperm are made in the testicle, they get put into the epididymis and then they go through the vas deferens tube and then out the penis during sex. Certain sexually transmitted infections can cause inflammation and scarring in that epididymis that can block the flow of sperm and make it difficult for the sperm to get out. The sperm are still being made, but they can't get out. Other infections might cause a decline in sperm production. And there's other viral infections that can happen, especially in childhood. One called Mumps, which is not a sexually transmitted infection, but it is a childhood illness that can affect fertility by decreasing the sort of production of sperm in the testicles. And on the female side, I'll let Dr. Schon answer that as well.
Thank you. Yes, so a history of sexually transmitted infections, most commonly gonorrhea or chlamydia, can cause inflammation of the fallopian tubes that may later in life lead to blockage of the fallopian tubes. So certainly, as I mentioned, that's one of the reasons that we assess the fallopian tubes in all of our patients undergoing treatment, because that is sort of one of the leading causes of what we call tubal disease.
Thank you again, both, for that answer. The next question I'm going to push towards you, Dr. Schon. If a woman under 35 has an issue known to potentially cause fertility issues, i.e. prolactinoma, should she still wait a year before seeking fertility assistance? And apologies if I mispronounced that.
Your pronunciation was perfect. No, that you are absolutely right. If you have a history of a prolactinoma, if you have PCOS, if you just have irregular periods and you don't know why, certainly you should be evaluated sooner. We know that for pregnancy to occur, you need to release an egg. And if you are having really irregular periods, then you may not be doing that. So I certainly wouldn't recommend waiting a year in that case. It makes a lot of sense to be seen. And specifically prolactinomas, because we know that elevated prolactin can affect the length of the menstrual cycle. That would certainly be an indication to be seen more quickly.
And the same, I would say, on the male side as well, that if men have any really reason to concern, and whether it was a childhood or a younger cancer treatment or some other pituitary issue, or just any other reason that they may be concerned, they're always welcome to come to an evaluation before 12 months.
Thank you again, both, for that. The next question we have up, I'm going to push to you, Dr. Schon. My wife and I are in a same-sex relationship and are interested in having a baby soon. Does your office offer fertility services for LGBTQIA+ patients?
Yes, absolutely. I know we've been talking a lot today about sort of heterosexual couples, but we certainly offer all the same samples, regardless of relationship status. So obviously to LGBTQ patients, to individuals that are unpartnered, these same technologies that we use can be applied here. So we're interested in helping anyone who wants to have a family achieve that family.
Thank you so much for that, Dr. Schon. The next question we have up reads, I'm in my late 30s and not ready for children just yet. What is the best time for me to freeze my eggs?
This is a tricky question without an entirely straightforward answer. And I would say because there's a lot that goes into this. So we talked a little bit before about how women are born with all of the eggs they're ever going to have, and that number declines with age. There have been different attempts to look at this. So we do a lot of egg freezing for women that are either single or for whatever reason know that they're going to be deferring childbearing for a number of years. The follow-up questions to this are sort of, how big of a family do you want to have? If your ideal family size is one child, then, you know, freezing eggs in your late 30s is reasonable. If you'd like to have a family of 5, then I'm probably going to recommend freezing your eggs earlier. There's no number of eggs that guarantees a future live birth, but there are probabilities of 1 live birth or 2 live births or 3 live births, depending on the number of eggs and the age at which you freeze them. This is a patient that I love to see and have a conversation about because it's more complex than just when should I freeze my eggs. You really have to think about what your ideal family looks like.
Yes, thank you so much for that, Dr. Schon. And another question for you. Does your clinic have an age cutoff for IVF?
So we do not have an age cutoff for IVF. We will consider individuals in their, early mid-40s. What I will say, and Brandi, please correct me if I'm wrong, but if you have U of M insurance, IVF is only covered up until your 43rd birthday.
Yes, that is correct.
And the reason for that is, the chance of success with IVF using your own eggs once you get into your mid-40s is really quite low. Now, we certainly assess patients on a case-by-case basis, looking at those tests like ovarian reserve to determine how good of a candidate someone is. And it's really an individual assessment and a discussion of likelihood of success and cost and weighing all of those things. But we don't have a hard cutoff.
Thank you. Thank you for that, Dr. Schon. Dr. Dupree, the next question I have for you, and it reads, my husband has had a vasectomy, but we would like to have children. Will he need to have surgery? And if so, how soon will he start producing sperm again?
Sure, thanks for that question. And just so we're all on the same page, a vasectomy is a procedure that's performed on men where we make basically a cut into the vas deferens tube. The vas deferens tube is a tube that carries sperm from the testicle up to the penis. And so when men have had a vasectomy, it's usually done with the intent of not having a larger family, at least not a larger family that involves his sperm. But plans change. And so if someone wants a larger family and the male partner has had a vasectomy, there's really 4 ways that they can have a bigger family. 2 of the ways involve his sperm, and 2 of the ways don't involve his sperm. The ways that do not involve his sperm involve using adoption to build a family or using donor sperm combined with an insemination procedure for the partner. I think the person asking this question was probably asking more about the two options that involve his sperm, and those are either to do a sperm extraction procedure or to do a vasectomy reversal. And so he will need a procedure either way if y'all want to use his sperm to build your family. And I can just talk very briefly about kind of those two procedures. So the sperm extraction procedure is a procedure that we typically do in the clinic under local anesthesia. It's very similar in terms of pain as the vasectomy that he had gotten in the past. And we use a small needle and basically pull some sperm and tissue directly out of the testicle. Important to know that when we pull sperm out of the testicle, that sperm can only be used with in vitro fertilization or IVF. So if you all choose the sperm extraction route, you really are also choosing IVF. Those two things really go together. The alternative is to do a vasectomy reversal surgery, which is a surgery done in the operating room. It is a longer and more involved procedure than the vasectomy itself. Depending on exactly what type of connection we're able to perform in the operating room, he'll start making sperm, hopefully within about 2 to 3 months. Although there are some types of connections that take a little bit longer to heal, and it might take longer. It might take upwards of 4 to 6 months for some patients. But we hope sooner than that for most men.
Thank you for that, Dr. Dupree. Dr. Schon, next question for you. When is the best time to have sex to get pregnant, and how often?
Yeah. So I think this is really about determining the most fertile part of the month, and there's a number of ways that this can be determined. I think most of the people I see are using some sort of app, and it doesn't really matter which one you use, they all work pretty much the same. If you wanted to do it app-free, you could sort of just determine the length of your usual cycle. So counting day 1 is the first day of full flow of your period, and then counting forward. It's normal for a menstrual cycle or a period cycle to vary within a couple of days. And that variation is usually due to the growing egg in the first half of the menstrual cycle. Ovulation typically happens in the middle of the cycle. So for example, if you are someone who has a 28-day cycle, you count back 14 days. And so that person is most likely ovulating around day 14. If you have a 30-day cycle, then you're most likely ovulating around day 16. And the other thing that a lot of people use are ovulation predictor kits, which are tests that check the urine for something called the LH surge. And the LH surge, when you catch it, usually precedes ovulation by about a day. So if you're using ovulation predictor kits, your most fertile days are going to be the day of a positive kit and the following day. If you are not using ovulation predictor kits and you're just sort of counting based on your cycle, you usually want to have intercourse about every other day, starting about 5 days when you think your ovulation is going to occur. So for that patient that has a 28-day cycle and we think they're ovulating around day 14, then I would say have intercourse at least every other day, cycle days, 9 through 15 to cover your bases. Data doesn't really show a difference between having intercourse every day or every other day. And again, if you want to focus on your 2 most fertile days of the month, then those ovulation predictor kits can be really helpful to help you find those 2 most fertile days.
Thank you for that, Dr. Schon. The next question related to this that you touched on reads, I'm having regular periods, but my ovulation predictor kit is negative. Does this mean I'm not ovulating?
Unfortunately, these ovulation predictor kits can be a little bit tricky, and they certainly don't work for everyone. So if your ovulation predictor kit is not working, but you're still having regular periods, then most likely you are ovulating. And in that case, I would probably use an app to help you find that window or sort of count backwards 14 days like we talked about. Again, if you're concerned and consistently not getting positives and you're worried, there's also pretty simple blood tests that we can do as well, just to confirm that you are ovulating. So that would be a great thing to talk to your physician about.
Thank you so much for that, Dr. Schon. And time flies. We have 15 minutes left, so we have quite a few questions. We'll try and get them answered for everybody. The next question we have up, I'll push to you, Dr. Dupree. Can you offer any diet advice, good foods to eat or foods to perhaps avoid? Does caffeine or alcohol affect fertility?
Yeah, so we get this question a lot too. And I think the best overall guideline that I can offer people is what's going to be good for your body is also going to be good for your sperm. That may sound kind of generic, but I think a lot of us do get messages about kind of healthy eating. And for the most part, those messages will also be good for your fertility and sperm. To get a little bit more specific, I do encourage men to try and make sure that their diet includes whole grains. Fish looks like that it is probably better for fertility, although it's best to avoid fish that are known to be high in mercury, such as tuna or mackerel or swordfish. Also, there are certain fats that are good. So nuts, avocados tend to be good. Fruits and vegetables are also excellent, and encourage men to eat about 5 to 6 servings per day of vegetables and about 2 to 3 of fruit. I encourage men to avoid heavily processed meats, also avoid red meats, and kind of limit saturated fat intakes or other whole fat dairy procedures. Caffeine and alcohol in moderation are fine. And what I mean by moderation is probably 1 or 2 cups each of either caffeine and or alcohol a day is likely fine. We do know that tobacco is bad for sperm. We also know that THC, the active ingredient in marijuana, is bad for sperm. So regardless of whether it's vaped or smoked or consumed as an edible, even though it's legal, both tobacco and marijuana in Michigan at least, we do encourage people to avoid them while they're trying to get pregnant.
Thank you for that answer. And I see Dr. Schon nodding as well. The next question for you, Dr. Dupree, it reads, what type of lubricant should we use if we're trying to get pregnant?
Yeah, that's a really great question. And so most lubricants that you can buy from the drugstore actually impair the movement or the motility of sperm. And so we discourage people from trying to buy most of the things that you can get at the drugstore. And I say most because there is at least one commercial product that's been shown to be safe for sperm, and that's one called Preseed, Preseed. I have no financial relationship with them. They're just the one commercial product that has been tested and looks like it's safe for sperm. Also, actually, believe it or not, from your kitchen, vegetable oil, canola oil is safe for sperm as well, and usually kind of handy and pretty cheap in bulk. So, people don't have to go out and buy any sort of special lubricant. And none of these lubricants are actually going to boost fertility. And so if both partners' bodies are producing enough lubrication on their own to have sex be enjoyable and pain-free, then we actually encourage people to just use the lubrication that their bodies are making. But for some people, that's not enough and sex is uncomfortable. And so if sex is uncomfortable, then canola oil, vegetable oil, Preseed are 3 that are perfectly safe for sperm.
Thank you for that, Dr. Dupree. Question for you, Dr. Schon. How long after trying to conceive should you see someone, and should you directly try to get in with a specialist or go to a primary provider first?
So as we mentioned before, we see a lot of patients with what we call secondary infertility, meaning that they've had a pregnancy before. And the guidelines for that are really the same. So if you're under 35 and you've been trying for a year, then I recommend that you come see us. If you're over 35 and you've been trying for 6 months, similarly, I would say that I think it never hurts to reach out to your primary care provider, especially because you'll hear from Brandi, a lot of times you'll need a referral to our office. I think, you could touch base with them and let them know. And most of the time they're very happy just to refer you to come see us.
Thank you for that, Dr. Schon. Dr. Dupree, I'll pass over to you now. What is a normal sperm count?
Yeah, it's a really important question. And right off the bat, I just want to let folks know that a sperm count is an imperfect test of fertility. And what I mean by that is there are some people that have high sperm counts that have trouble getting pregnant for other reasons, or a variety of reasons. There are some people with low sperm counts that are able to get pregnant. And so it is not sort of the definitive end all be all of fertility. I think it's really important for people to know that even before we start talking about sort of normal values. But nevertheless, we do have to have some sort of sense for what's sort of typical. And so the way we've sort of determined what's a typical sperm count is actually the World Health Organization got volunteers from around the globe who had all had children within the past 12 months to provide a semen sample. And they took all these sperm counts from all of these men that all had children within the past 12 months, and they sort of pooled them together. And they just decided that basically the range that would cover 95% of the men in those samples is what we're going to call normal. And the bottom 5% of men in that sample are what we're going to call low. And so that's how the reference ranges that you'll see on a sperm count report were created in the first place. Hopefully that's not too much detail for those that might want to know, but I think it's really useful to understand where these kind of numbers and values come from. And although the reports that men may get have sort of a low or normal that sounds kind of binary, it sounds black or white, in reality it's not. It's really a spectrum. So in general, more healthier sperm are better, but there's not some magic number that men have to exceed to be considered fertile, so to speak. So yeah, is that a fair enough answer? You think that answers the questions?
I think that's a great answer. We have another follow-up question that kind of relates to it. Again, I think that spectrum answer that you gave is fantastic. This question reads, once my sperm count goes low, can it come back up?
So it depends on why it went low in the first place. And so it takes the male body about 3 months to make sperm. And so if something happened, if he was taking testosterone, if he had an infection of the testicles, if he had a high fever or a COVID infection. One other thing I should have mentioned earlier, hot tubs and saunas are actually too hot for the testicles. So let's say he was on vacation and was on in a hot tub for a couple days in a row. All of those things can kind of drop a sperm count. And it will take about 3 months for the sperm count to kind of go back to its old baseline values. And so 3 months or so is a rough average for how long to expect to see any changes after having done something, even something good, like maybe starting a new medication to help with fertility. It takes about 3 months to see the results.
Thank you, Dr. Dupree. We have a few more questions related to sperm count. This is something you touched on. What are some treatment options for men with a low sperm count?
Yeah, so again, I think it depends on the underlying reason. So if the man is discovered through our investigations to have low testosterone, there are actually medications we can use to safely raise his testosterone levels in a manner that's safe for his sperm. These are not injections or creams, like I mentioned earlier. Some men have what are called varicoceles, which are enlargements of the veins in the scrotum, and fixing a varicocele can improve both sperm counts and chances of getting pregnant. I would also consider a treatment to be something like quitting smoking or weight loss. Those are treatments in my eyes because we know that both smoking and being overweight are other things that can make a man have a lower sperm count.
And again, this is another sperm count related one. Are there any supplements you recommend that can boost sperm count, motility, morphology?
Yeah, a very, very common question. And there are no supplements that I push or tell men that they need to take. As I mentioned earlier, I think a healthy, balanced diet should be giving men all of the nutrition that they need. And frankly, the research on individual supplements is, it's kind of weak. And so the studies that have been done on this vitamin or that supplement, sometimes the studies show a slight improvement in one sperm number versus another. Other studies show no change at all. And really none of the studies of supplements have any shown a meaningful change to the pregnancy, to the chance of getting pregnant, which is I think what most people are really searching for. If men are really committed, they really want to take a supplement, there are some that I will tell them that, they can take if they want, just to try and avoid them from having to spend money on totally expensive things. But in general, again, I think a healthy, balanced diet should give men all of the nutrients that they need.
Thank you for that. I'll combine the next two questions into one question, still on the topic of sperm count. Will abstaining from sex help my sperm count rise back up? And does masturbation help or hurt the cause?
Yeah, so there's an interesting relationship between abstinence, meaning how long it's been since you've last ejaculated, and sperm numbers. So the longer the abstinence has been, the concentration, the number of sperm does tend to increase to a point. But also the longer the abstinence, the lower the movement of the sperm goes, because the sperm are sort of older and sitting around a little bit longer. They're not quite as fresh. And so as Dr. Schon mentioned, when trying to conceive, we really recommend that couples have sex either every day or every other day. Waiting longer is not necessarily better. Having sex more than once a day is also not necessarily better. Technically abstaining will raise the sperm count a little bit, but other things will get worse as a result. And so it's really a balance. And in terms of masturbation in and of itself is not a unhealthy, harmful or hurtful thing. It's really all about how it's used in a person's sexual life. I mean, masturbation is a normal part of sexual health for many adults. If it starts to interrupt a man's ability to have intercourse with his partner, well, then it may become a problem. But masturbation can also be just an also normal, healthy part of life.
Thank you for that, Dr. Dupree. Dr. Schon, next question reads, how does stress affect our ability to get pregnant?
This is a question that I get all the time, and there is really not good biological data to suggest that stress causes infertility. Unless you are so stressed that it's causing you not to have periods, in that case, it could impact your ability to get pregnant. But just dealing with stress, everyday stress in times of COVID, the stress with infertility, there's not good evidence that that causes infertility. Along those lines, I think it's really common. Well-meaning friends or family will say, "Just relax, and it'll happen." And while it's well-intentioned, a lot of times that can sort of increase feelings of isolation, and it's not really biologically supported.
Thank you for that. Another question for you, Dr. Schon, that just came in. Is there any specific information or data tracking that's helpful to bring when coming in after 1 year of trying to conceive?
Yeah, so I think that, in gynecology, we consider the menstrual cycle and your period a vital sign. And so almost all my patients come in with their periods really tracked out with these apps, but having a good idea of sort of what your cycles are like. If you're using ovulation predictor kits, especially if you're timing intercourse around those, writing down when they're positive in relation to when they start your period is really helpful. So I think in terms of tracking, that's probably the most useful information to have, but I also don't want patients to go overboard, because as Dr. Dupree and I mentioned, if you're having intercourse around every other day, sort of throughout the menstrual cycle at various times, you're still doing everything right.
And on the male side, I would just very briefly ask that if men are coming in to see their doctor about this, and if you have had a sperm count before, it's really useful to bring that result and have that with you. That's a piece of data that's really useful for me as a urologist. And understanding the timing of that sperm count relative to any other medical issues. So when was that sperm count relative to if you had been sick and had a fever, or when was the sperm count relative to having started or stopped any other medications?
Thank you so much for that, Dr. Dupree. We are coming up to the top of the hour. I would love to just send you this one last question, Dr. Dupree. It's a massive question. You've already dipped into it with regards to hot tubs being perhaps bad for fertility, but could you talk about male fertility as it relates to some of the following: having a laptop in your lap, a cell phone in your front pocket, boxers or briefs, perhaps riding a bike? Should you be worried about groin injuries? I know this is a massive question that you could probably take 10, 20 minutes on, but I'd love just a few responses to those.
Sure, and I'll try and be brief. So laptops, try not to have it directly on your lap. The heat of the battery underside the computer is what we worry about. They sell these really nice lap desks that you can put the desk on your lap and then the laptop on the desk, and that keeps the heat away from your testicles. Regarding cell phones, frankly, we don't really know. It's probably okay, but there's some kind of mixed data research that's been put out about cell phones. I carry mine in my pocket for whatever that's worth. If you're really worried, then maybe get a little clip that goes on your belt instead, but it's probably okay, but we're still learning. Boxers or briefs don't look like they really matter. It's really whatever's going to be comfortable for a patient. Bike riding, I will say exercise is good for you and also good for your sperm. The key thing about bike riding is you want to make sure that the seat fits you well enough that you're not having any pain or numbness or tingling in your perineum or your penis or your testicles. If you're having any of those symptoms, then you just need to get a better bike seat. Groin injuries, maybe it depends on the injury. And in particular, if you had surgery that could potentially cause scarring that might block the flow of sperm, it's really going to depend on the specifics of that.
And thank you for going through all those permutations and questions in one go. But just before we close, I want to ask: are there any final thoughts that you guys have for me? And then we'll move into the close.
I guess I'll just mention quite briefly, and I touched on this earlier, but I think it's also really important for folks to remember. There's a lot of really wonderful ways to build a family. So we've spent a lot of time here talking about eggs and sperm and sex. And that's certainly a way that many people build their families, but using adoption, using donor sperm, donor eggs, even donor embryos are also really common ways that people build their families. And so I want to make sure that we're kind of inclusive as we talk about family building, because I've had many patients that have gone down some of those routes and have these really wonderful families to show from it. So thank you for all your time and questions today.
And if I can piggyback off of Dr. Dupree, on the website, there is a link as well. You know, this journey can cost a lot of patients, a lot of finances. So there are resources out there, and it is called Revolve. And if you click on there, they can assist you with different resources and help you on that journey.
Thank you so much. Dr. Schon?
Yeah, just thank you again for having us, especially being that it's National Infertility Awareness Week. Just reminding patients how common this is and that you're not alone and no one should have to go through this alone. And encouraging people to reach out with any questions. We talked a lot about, infertility is diagnosed at this, a year or 6 months, but we're always happy to see patients with questions or concerns. We have a lot of resources to offer. So thank you.
And thank you. So as we close in on the end of our chat together today, Dr. Schon, Dr. Dupree, Brandi, thank you all for sharing your time and expertise. I know that was a lot of questions we got through. All three of our panelists work out of our Center for Reproductive Medicine in Ann Arbor. To make an appointment, you can call 734-763-6295. That's 734-763-6295. And information about their clinics are also available at ufmhealth.org/fertility. I'll repeat that again, ufmhealth.org/fertility. Thank you to our audience too for spending part of your afternoon with us. We hope that today's chat has been helpful, and we have a brief survey we've prepared to help us learn how we can make chats like today's more helpful, and to help us identify more topics you'd like to hear about. If you registered in advance, you'll receive an email with the link, or you can check the comments in this video too. So thank you in advance for your time. And if you're interested in sharing the recording of today's chat with others, you'll find it on our Michigan Medicine social channels and also on our Michigan Medicine YouTube channel. So again, thank you for joining us and have a wonderful afternoon.